Hello, everybody. Today we're talking about malignant glaucoma, which is a bit of an enigma. It's a very difficult problem in many cases, but sometimes it has a more subtle presentation that is not always talked about. So I wanted to talk about the full spectrum of malignant glaucoma, from the dreaded to the to the mild. I have no financial disclosures about this presentation. And I want to start by talking to you about a patient I had probably in the mid-90s. He was referred into me for, and oh, by the way, I call him Mr. Dark Cloud over my head because everything was just so difficult in his care, first in one eye and then in the other. And it all centered around malignant glaucoma. He was referred in for elevated intraocular pressure, and he had chronic angle closure glaucoma, and he was pseudophakic. He had previously failed non-penetrating glaucoma surgery in both eyes. I performed a trabeculectomy. It was uncomplicated. He was great on post-op day 1, great on post-op day 5, deep anterior chamber, and his pressure was in the low teens. On post-op day 8, despite having a patent iridectomy, a nice wide-based iridectomy, he had iris prolapse into the sclerostomy. And in retrospect, he was on prazosin. We didn't know a lot about IFIS back in '95, idiopathic floppy iris syndrome, but he was on prazosin, which was an alpha adrenergic blocker. So most likely the reason he had this iris prolapse was because of IFIS, and he had a deep anterior chamber. So I gave him pilocarpine to try to pull the iris out of the sclerostomy. And he came in the next day with a pressure of 45 and a flat anterior chamber and an otherwise normal posterior pole. So he was in malignant glaucoma. And what is malignant glaucoma? It is a secondary form of angle closure glaucoma, and it's a posterior pushing mechanism where vitreous pressure pushes from the back of the eye to shallow the front of the eye. It was first described by von Graefe in 1869 because he called it malignant because of its unrelenting course, unresponsive to therapy. And people really didn't know what to do. People just usually lost their eyes if they went into malignant glaucoma. In the 1950s, Chandler described lens extraction to treat malignant glaucoma, but it turned out that was only successful if there was vitreous loss at the time of lens extraction. So there's usually an inciting event, usually, but not always. And it can happen after incisional surgery, and it can happen after any incisional surgery. Typically, we hear about it after glaucoma surgery or cataract surgery, but it can also happen after lasers, any laser, iridotomy, cyclophotocoagulation, even a capsulotomy or suture lysis. It can develop if you have a wound leak, and it can develop if you withdraw cycloplegics. So I'm going to say this a couple of times. Beware of the patient that comes to you on cycloplegics, because there are some people that are on chronic cycloplegics because if you take them off, they go into malignant glaucoma. They may not know, they may not have been seeing doctors regularly, but just beware of the patient that comes to you on a cycloplegic and be careful withdrawing it. It can happen, malignant glaucoma can be incited by inflammation, and it can develop intraoperatively. And I'm sure many of you have had this experience where you're operating and all of a sudden, say you're doing even just a cataract surgery and the eye just gets firm and it's hard to form the anterior chamber. That can be intraoperative aqueous misdirection of malignant glaucoma. And in my case, it started with the institution of miotics. So when I administered pilocarpine to try to pull his iris from the sclerostomy, it precipitated a full-blown attack of malignant glaucoma. And we performed a vitrectomy. We tried to treat him medically, and we tried to treat him with laser, but he required a vitrectomy with removal of the anterior hyaloid. And we'll talk later about how IRIDOZONULOHYALOIDOTOmy is the treatment of choice now, but this was back in 1995, and we didn't really understand that at the time. And he still, to this day, I still see him. He requires chronic atropine to keep his pressure, to keep his eye formed, and to keep him from going back into malignant glaucoma. What are the risk factors? Typically, we see this in high hyperopes and often in eyes that had chronic angle closure or chronic narrow angles. But it can occur with pseudophakic. It can occur in phakic eyes, pseudophakic eyes, or even aphakic eyes, because it has to do a lot with the vitreous base. It can sometimes occur spontaneously also or after trauma. And it's a bit more common in women and people with pseudoexfoliation. But most people with malignant glaucoma don't have pseudoexfoliation. And the mechanism is controversial. There seems to be usually some type of precipitating event, but not always, that leads to an altered interaction between the ciliary processes, the lens, and the vitreous base. And this causes aqueous not to move anteriorly like it's supposed to through the pupil and into the anterior chamber, but it forces it back into the vitreous cavity. And then these pockets of aqueous form in the vitreous, and expands the vitreous and then causes shallowing in the front of the eye and angle closure. Oh dear, this changed formatting. Excuse me for a second. And the print is very small. So we have aqueous directed posteriorly, which then compresses the anterior vitreous. And when the anterior vitreous then gets compressed, it becomes less permeable and it creates a barrier for the movement of aqueous anteriorly. So you get this decreased permeability across the anterior vitreous and the anterior hyaloid, and you get this positive pressure building up in the vitreous cavity, which shifts the lens iris diaphragm forward, causing shallowing or flattening of the anterior chamber. And this is really distinguished. This is a very important point. It's distinguished from iris bombay. It's distinguished from like a pupil block, because the whole center of the iris, the whole center of the anterior chamber is shallow. The lens shifts everything forward. Usually in iris bombay, the lens doesn't come forward. You have narrowing and iris comes forward in the periphery, but the center chamber is still formed. In aqueous misdirection, everything comes forward. You get angle closure and usually elevated intraocular pressure. So what are some contributing factors? Chandler and Grant postulated that zonular laxity, loose zonules, allow the movement of this lens iris diaphragm more readily, and then with the increased vitreous pressure, and it lets people go into this malignant glaucoma more easily. Trope in '94 described ciliolenticular block, and he described ultrasound findings that talk about this rotation of the anterior rotation of the ciliary processes, when then having a supraciliary effusion, and that whole supraciliary effusion causes expansion of the vitreous cavity. And Quigley firmly believes that the precipitating event is this choroidal expansion. And that's why Quigley doesn't like the name aqueous misdirection. I believe he likes malignant glaucoma, but he doesn't believe aqueous misdirection is the hallmark of the disease. He believes choroidal expansion is the inciting factor. And Liebman described 6 eyes who had UBM and confirmed these peripheral annual choroidal detachments. And another mechanism is this impermeable anterior hyaloid. In this study by Balakoudaru, he looked at 58 eyes with malignant glaucoma. That's a pretty big series. And the majority of the eyes had this anterior rotation of the ciliary processes and shallow or flat anterior chamber. He found that only 10% had supraciliary effusion on UBM. And when they tried sclerotomies to see if that they could drain this fluid and bring everything back, bring the positive pressure down and deepen the anterior chamber, he found that they couldn't find supraciliary fluid. So it brings into question this whole notion of whether, choroidal expansion is the underlying problem or this anterior rotation. It's still controversial, and certain people feel very strongly about it. Thankfully, malignant glaucoma is relatively uncommon. In the tube versus TRABS trial of 242 patients, malignant glaucoma developed only in 3% in the glaucoma drainage tube group and 1% in the trabeculectomy group. So making the diagnosis, and like I mentioned, it's all about that lens iris diaphragm. In malignant glaucoma, there is central shallowing of the anterior chamber because the whole lens iris diaphragm pushes forward. And that's why it's distinguished, as I had mentioned, from pupil block. which the lens iris diaphragm doesn't shift forward. It's the peripheral iris that comes forward. And there's a normal posterior segment on exam. The typical presentation is pain, high pressure, a shallow to flat anterior chamber, particularly centrally. And this is the full-blown malignant glaucoma presentation. Poor vision from corneal edema and refractive changes, because when that lens iris diaphragm shifts, the refraction changes, and there's a normal posterior segment. And what we see on UBM here, on the slide on the left, and this is from Dr. Felipe, we see that anterior rotation. Those red arrows are pointing to the anterior rotation of the ciliary body. And then you can see on the slide on the right, the forward displacement of the lens iris diaphragm. That's iris smack up against the cornea in this picture right here. And here we can see from this paper by Gonzalez Martin Moro, pre and post vitrectomy, and look at the difference in the anterior chamber. On the slide on your left, your anterior chamber is a sliver. Everything is shifted forward. And after the vitrectomy, you can see how the anterior chamber is nicely formed. There's a IOL in the posterior, behind the iris in the posterior chamber. And there's a nice deep fold on the anterior segment. So the differential diagnosis, when we look at people that have high intraocular pressure and shallow anterior chambers, or pupil block, choroidal hemorrhage, and malignant glaucoma. And from what we talked about already, we should be able to make this differential. The difference between pupil block is because in malignant glaucoma, there's central shallowing. And the difference with choroidal hemorrhage is that the malignant glaucoma, the posterior segment is normal. The intraocular pressure is typically very high, but sometimes in malignant glaucoma, you can have a relative malignant glaucoma, and sometimes the intraocular pressure may not be high. So can malignant glaucoma not be malignant? And the answer is yes. So you can have relative aqueous misdirection, and that's when the anterior chamber becomes shallow but not flat. So if the malignant glaucoma is starting and the lens iris diaphragm starts to shift forward but hasn't closed off the angle yet, you can have shallowing of the front part of the eye without actually closing the angle, and the IOP may not be elevated. The other way you can get high IOP in malignant glaucoma, low IOP or normal IOP in malignant glaucoma is if you have a functioning filtering bleb. So even though everything is shifting forward and you may have angle closure, you have a functioning filtering bleb draining the pressure, lowering the pressure. And let me just tell you about Mr. just had cataract surgery. I had two of these patients right in a row. It's very interesting. 60-year-old white gentleman with hyperopia, 425 in the right, 3+3 in the left, moderate cataracts, extensive PAS, right more than left, and normal pressures. He had laser iridotomies at age 50. He had relatively short eyes, 21.1 millimeters on the right, 21.6 on the left. And we planned cataract extractions in both eyes and some goniosynovial lysis for long-term angle health. Did the surgery on his left eye first. So this is the eye that's slightly less hyperopic, slightly longer eye. And we put in a 28 diopter lens. So you know it's a small eye. And we gave him atropine in the operating room, which I strongly recommend in any time you operate on a high hyperope or anyone with significant angle closure or narrow, very significant narrow angles with compromised angles. So I gave him atropine in the operating room. He had an uncomplicated post-op course. He was -1/4 on post-op in his post-op. Operated on his left eye, on his right eye a month later. He needed a 31 diopter lens. The OR didn't have atropine that day, so I gave him additional cyclogel. I told him to get atropine, and the next day he came in and he said, "Doc, my eye feels fine and I can read great, but everything else is blurry." And he was a -2.5 diopter refractive surprise. His pupil was still dilated, so it wasn't that he wasn't dilated, but with cyclogel, you can get dilation without adequate cycloplegia. His anterior chamber was flat peripherally, formed centrally, but clearly, even though it was formed centrally, it was shallower than the left eye. His pressure was 10, it wasn't elevated. His fundus was normal, there was no wound leak. This was classic relative malignant glaucoma. We treated him with atropine and dorzolamide timolol. And again, we'll get to cycloplegia and aqueous suppression. So we may as well start talking about that. The treatment is cycloplegia and aqueous suppression. And the next day he says, getting clearer. And he was a -1, and his anterior chamber was deeper and only slightly shallower than the other eye. And then post-op week 2, doing great, -1/4 diopter and with a deep anterior chamber. So like I said, I had 2 cases right in a row. Round 2, 53-year-old woman with appositional angle closure scheduled for cataract extraction with goniosynucleolysis, axial length of 22, anterior chamber depths of 2.5 with steep corneas. 22.5 diopter lens was placed. Left eye was treated intra-op and post-op with atropine, came in post-op day 1 at 20/20. Other eye received a drop of atropine in the operating room, but she didn't start it on her own. She came in again post-op day 1, 2100, but J1+. So again, clear near vision, a refraction of -3 with a shallow anterior chamber and a pressure of 11. And she responded to atropine within the hour. 1 hour after atropine, I'm not sure if these pictures do it justice, she was deeper, and 1 week she was perfectly normal with a normal refraction. And I've had other cases since then. So atropine. I've had a slew of nanophthalmic eyes, and there you absolutely need to use atropine postoperatively. So when I think now of the differential diagnosis of normal or low intraocular pressure and shallow chamber, this used to be my differential. Normal or low pressure and shallow anterior chamber with serous choroidals, overfiltration or wound leak after trabeculectomy. But now we can add to that relative aqueous misdirection, or relative malignant glaucoma. You can have a normal or low intraocular pressure and a shallow chamber. In terms of medical management, we have this stepwise approach. And again, we want to talk about cycloplegia, and then some more cycloplegia, and atropine. If you can use atropine or home atropine is really vital, much stronger than cyclogel. And so cycloplegia is #1 over and over. And then aqueous suppressants are also very helpful as #2. And make sure you discontinue miotics. I've seen people come in on miotics and cycloplegics, and that doesn't make any sense. And miotics can incite aqueous malignant glaucoma. So you want to get off of the miotics. So stepwise, atropine or home atropine, and people may need it permanently. You have to be very cautious. I worked initially at University of Pennsylvania from the Shea Eye Institute, and I inherited a patient of Dr. Shea's who was his nurse for years, and she needed atropine for the last 30 years of her life. And if you tried to decrease it, or even every few days, she would just shallow up. Cycloplegia tightens the zonules, pulls the lens iris diaphragm posteriorly, and it expands the ciliary body to make it easier for aqueous to percolate through. And it pulls the ciliary body away from that lens vitreous hyaloid interface. Remember, we talked about that anterior rotation of the ciliary processes. This pulls, the cycloplegia pulls it back. Aqueous suppressants. So we want to decrease the amount of aqueous that may be going back into the vitreous cavity. So beta blockers, carbonic anhydrase inhibitors, and alpha agonists can sometimes be helpful too. You can try hyperosmotic agents to decrease the vitreous volume. Anti-inflammatories are sometimes important, especially if this is associated with a surgical or lens procedure. And remember to discontinue the miotics. It's written, and I'm not sure there's great evidence for what has been perpetuated through the literature, but it's written that 50% of attacks will end with medical management. Certainly, it's worth giving a number of days, usually up to 5 days, if people can be moderately controlled with medical management. You can, but lasers can be helpful, and there's no sense in waiting too long to go with laser treatment. You can perform an iridotomy if there's not already one, and that's really important just to make sure that there's not a component of pupil block. But that's not going to treat the malignant glaucoma. For that, you need to do a YAG laser disruption of the anterior hyaloid. If there's pseudophakic, go right through the center of the pupil through the PCIOL. If they're phakic, you can go through the iridotomy and try to do it more peripherally. There's some reports that say it may be more efficacious to perform it inferiorly, because that may open up some pockets of aqueous that are settled inferiorly. In this study, there were 10 pseudophakic eyes with malignant glaucoma, first treated with an inferior laser peripheral iridocapsulhyaloidotomy. That's a laser through the iris, through the capsule, and through the hyaloid. And 7 out of 10 patients in this group had full resolution of the malignant glaucoma. 3 required pars plana vitrectomy with zonulocapsulhyaloidectomy and an inferior iridotomy. And they postulate that the inferior laser may better reach those pockets of aqueous to break the block. You can also consider, and I personally haven't done this, but it's very intriguing thought, transscleral cyclodiode laser photocoagulation in pseudophakic or aphakic eyes to shrink the ciliary processes by photocoagulation and cause the posterior rotation and break the block. And in this study, Lin described using low-dose CPC and achieved durable resolution of malignant glaucoma. So as I mentioned, the literature states that about 50% of cases will not break with medical and laser management, though we have seen from previous laser studies that their results might be better. We didn't understand in the past. We thought you could just do a vitrectomy and that would be adequate. But that's not adequate at all. You need to break that hyaloid membrane, and you need to establish a pathway of aqueous from the back of the eye to the front of the eye. So doing a vitrectomy, I can tell you from that first patient of mine, Mr. Dark Cloud over my head, vitrectomy did not cure him at first. You need to do more than that. A pars plana vitrectomy, we also need to go from the front of the eye to the back of the eye with an iridozonulohyaloidotomy. So you need to get through the iris, the zonules, and the hyaloid. Get right through there with your vitrector, and need to remove anterior vitreous. As it turns out, you probably don't need a complete vitrectomy, but you need to get a good bit of anterior and central core vitreous. And you need to create a durable conduit to connect the anterior chamber to the vitreous cavity. Most people will usually remove the lens in phakic people. In this study by Zarnowski, yes, 10 eyes of 9 patients, pseudophakic malignant glaucoma, and they performed anterior chamber approach to a capsule hyaloidectomy with an anterior vitrectomy, and they did this through a peripheral iridectomy. So this is not with trocars, this is just going from an anterior approach through a PI right into the vitreous, and they broke all of the cases and did not have recurrences. And if you notice, he had 10 eyes of 9 patients. So it is really common if you have a problem in one eye, you may have a problem in the second eye. So you really need to beware. In this study, again, by Balakoudaru, 58 eyes with malignant glaucoma. In these, the majority of the eyes had that anterior rotation of the ciliary processes. They had success in 86% of patients that just had vitrectomy and lensectomy, but they had success in all the patients who had a connection between the anterior chamber and vitreous cavity. So I should qualify that. So some of those patients that had vitrectomy also had the conduit created between the anterior chamber and the vitreous cavity. The takeaway from here is that they had 100% success when they could create a pathway from the anterior chamber to the vitreous. So When you go in for surgical treatment of malignant glaucoma, a vitrectomy is not what you should be aiming for. You need a vitrectomy with an iridozonulohyaloidotectomy. And this just shows a technique, a mini vitrectomy, and this can be what they refer to as a simple solution to a serious condition, where you make an incision just through the peripheral cornea. They nicely inject triamcinolone behind the IOL, and that way you can see the vitreous very nicely. They put that vitrector probe right through. You can do an iridectomy right down through the iris into the vitreous cavity. You'll see that you're taking out the vitreous because of the triamcinolone staining, and then it's through a simple anterior segment incision. We tend to send these patients to retina, who will do a formal vitrectomy, but we make sure our retina colleagues are aware that they need to create this conduit from the front of the eye to the back. There will be recalcitrant cases, and it often happens if there's failure to establish communication or if that communication fails. There are patients that just have intense inflammatory reactions, and they can scar over all sorts of conduits. So if you can't establish a pathway that stays because of whatever reason, things clogging it and or inflammatory membranes developing, you can be back to square one. What do you do in cases like last resort? What is your last resort? You can put a glaucoma drainage tube if you have a complete vitrectomy and you're still in aqueous misdirection, which really happens, and I have unfortunately seen this back in the 90s. You can put a glaucoma drainage tube directly into the vitreous cavity because that's where the fluid's going, and it can drain it right from there. You can also do whatever you need to do to establish a unicameral eye. You can take out the IOL, leave them aphakic, and make sure, as long as that anterior hyaloid and they have a vitrectomy with an aphakic vitrectomized eye, will not have malignant glaucoma because there's no barrier. And so if you are desperate and you have no other way of controlling this, that will always work. So back to my patient, this patient back from 1995, which, as you can see, has been very memorable for me. His second eye, we said, well, he's already had failed non-penetrating surgery in both eyes. That's how he was sent in to me. I did the trabeculectomy and got the first eye into malignant glaucoma, and he had iphus and floppy iris. The second eye, I'm going to just put in a glaucoma drainage tube and keep that patient atropinized. Well, I did all of that, and he developed malignant glaucoma unresponsive to laser hyaloidectomy, and it recurred and was retractable after vitrectomy, and we did remove the anterior hyaloid, but this was back in the 90s before we understood about iridozonular capsular hyaloidectomy. And he was ultimately stabilized by removing his intraocular lens and creating a unicameral eye. And this, as I mentioned, is the days before the IZHV. So, preventative measures. What might I have done differently in the fellow eye? Well, or what other things we can do. So certainly, no matter what, you want to discontinue miotics. If someone has malignant glaucoma in one eye, make sure you never use miotics in either eye. And don't be tempted to use Myocol or Myostat or post-op pilocarpine after cataract surgeries. There are some operating rooms where the post-op drop routine includes pilocarpine. You want to probably get that out of a routine post-op program, because if you have just people that are on the borderline with pretty narrow angles that you do cataract surgery, that little bit of pilocarpine can put them over. So you don't likely need it in a lot of surgeries, and you certainly don't want to use intraocular Myocol or Myostat in high-risk eyes. And I'm pretty liberal with using atropine after any intraocular surgical procedure in high-risk eyes, either fellow eyes, absolutely. But if I think the patient has, is a pretty high hyperope, they have some PAS from their narrow angles, I will give them atropine really commonly. I've just seen aqueous misdirection develop too many times. Try to avoid shallowing of the anterior chamber intraoperatively. Sometimes that just sets it off. And some people talk about doing the iridozonular vitrectomy prior to incisional surgery in the fellow eye. And that's food for thought right now. What about intraoperative aqueous misdirection? As I mentioned before, suddenly you're operating and there's a sudden increase in pressure and shallowing of the anterior chamber during surgery. First thought is always choroidal hemorrhage. And you establish there's got a great reflex. Maybe you take a look in the back and everything looks great, but you have a little bit of iris prolapse. You try to put a little viscoelastic in and the chamber just gets firm, but not deep. You're having relative aqueous misdirection intraoperatively, and it's not that uncommon. So what do? What will often work is treat with atropine and just sit there, but it's really hard for us surgeons to just sit there because you got to wait a while. You can try some IV mannitol and wait, but you still have to wait. And I usually give I'll give atropine and I'll give neosinephrine also, or intraocular epi also to dilate, but it can take a while. It will often reverse with atropine, but you have to be patient. And most of us really don't have a half an hour with the patient on the table to wait. You can, if you have a 25 gauge with a trocar, that's the best thing to do. Just go right in with the trocar and it'll deepen immediately. If you don't have that available, you can decompress. The retina doctors aren't in love with this, but you can decompress with a 25 gauge needle through the pars plana. It's not ideal. It has its risks, but you go in, chat a little bit, and with very minimal aspiration, the chamber will you'll get just some liquid aqueous coming through, and the chamber will just deepen. So if you have no alternatives, you can consider that. Well, what are our key takeaways from this? In malignant glaucoma, there is an anterior displacement of both the iris and the lens, and this causes axial shallowing, including central shallowing of the anterior chamber, and that is what distinguishes it from pupil block, which only really has peripheral shallowing. Pupil block, it'll look like the chamber is shallow because the peripheral chamber is flat with iris bombée, but in pupil block, the central chamber stays deep, whereas in aqueous misdirection, that lens can be right up against the cornea. Medical treatment is cycloplegia, 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 and then aqueous suppressants, aqueous suppressants. And so you just have to really, really treat hard. And you don't want to give atropine and tropicamide or Madrayacil, because the Madrayacil is going to compete with the atropine and it's not as strong as cycloplegic. So you want to give atropine, and if not, you don't have that. If you have home atropine, and really hit with strong cycloplegia and don't compete for it with your cyclogel. Laser you can try, so medical treatment 1, laser number 2, and surgical treatment requires the creation of a unicameral eye, and that has to be a durable pathway that aqueous can go from the back of the eye to the front of the eye. Beware of stopping atropine in someone who presents to you on long-term cycloplegic therapy. And you're like, well, why does this person need atropine? I wonder why. You know, they're pseudophakic, everything looks good. Just be really, really careful. And not all malignant glaucoma is malignant, that thankfully. And when we operate on patients with angle compromised, short axial lengths, and shallow anterior chambers, remember, atropine is our best friend. So I want to thank you. We have a couple of questions to ask you, and we can discuss those answers. So malignant glaucoma always presents with serous choroidal effusions, shallow anterior chamber, highly elevated pressure, and corneal edema. Very good. So shallow anterior chamber, that's the hallmark where there's posterior vitreous pressure pushing forward. And so it always presents with some shallowing, maybe not flat, but some shallowing of the anterior chamber. There are usually no visible serous choroidal effusions. Now, there may be annular ones that we can pick up on UVM, but when you examine the back of the eye, you are not going to see serous choroidal effusions. So that's a little bit of a tricky one, because often there on UVM, you can find these annular peripheral choroidal effusions, but you're not going to see that on exam. usually have highly elevated pressure, but we talked about those relative cases where they've shallowed, and maybe they have a myopic shift of their refraction, but they haven't closed their angle yet. And so they will not have elevated pressures in those cases. Also, if it happens in a patient with a functioning filtering bleb, you can have angle closure and really flat chamber, but still not have elevated pressures. Regarding the treatment of malignant glaucoma, surgery is always required to treat malignant glaucoma. Vitrectomy is curative. Pilocarpine should be given frequently, and atropine and aqueous suppressants are the first-line treatment. Very good. So atropine and aqueous suppressants are the mainstay of treatment. So that's cycloplegia and aqueous suppression. That is the classic way of treating malignant glaucoma. Pilocarpine should be stopped. That can incite malignant glaucoma. That was the cause of the malignant glaucoma, or the inciting event in my first patient that I talked about. Vitrectomy by itself is not curative. It may help in some people. Sometimes they'll relapse. So you need to get a vitrectomy, iridozonulohyalidectomy, and create a pathway. And surgery is not always required. So surgery, sometimes the literature says about half of cases will break on medical therapy. Good, so let's look at our Q&A here. What is the opinion about malignant glaucoma and normal intraocular pressure? So as I mentioned, you can have malignant glaucoma with normal pressure when it's relative, if the angle hasn't completely closed yet, and or if you have a functioning filtering bleb. So how do you differentiate capsular block syndrome from malignant glaucoma in a post-op exam of cataract surgery? Usually, when you are relative malignant glaucoma after cataract surgery, if it's mild and you're trying to figure out what this is, they'll have a myopic shift. So my patients, for instance, came in saying, I can read great, but my distance vision is not good. And their post-op refractions were myopic. Usually around, for me, they were both about a -3 or so. So you can, and if you look at the depth of the anterior chamber, if the other eye is already pseudophakic, you can really compare and see that it's shallower than the other eye. It's hard when one eye is pseudophakic and one eye still has their cataract, because they may have similar anterior chamber depths. But that myopic shift is one clear way. I will tell you about a patient I had recently. This is a patient that needed 35 diopter implants, lens implants. So this is a nanophthalmic eye, a very tiny eye. And I did, and so I was really unsure. I did her first eye surgery, definitely atropinized her. And she came in at like a -150 in her first eye the first day. And she has a small eye and her chamber was a little bit shallow. So I was trying to get her ready. I delayed the surgery in the other eye because I didn't know if my IOL calculations were off, because she's outside of the normal range that we see when we're figuring out intraocular lens implants, or if she was in a little bit of aqueous misdirection. And it turns out she was in a little bit of aqueous misdirection, and I let her simmer a little bit with atropine, and she settled down more to like a -70.75. So she was in like a little bit of relative, but in that case, it was hard because she has a tiny eye. She's not going to have a big deep chamber. And I was comparing it to her phakic other eye, which also has like a slit-like anterior chamber. How effective is laser iridozonulohyalidectomy in cases of malignant glaucoma? The results are variable. So there's a lot of different studies that look at this. And I think it's always worth trying. I don't think it's going to be the answer in the majority of cases. I think you should absolutely try to do a laser through the iridectomy and really get through the zonules and make a nice opening. And it will break some attacks. Whether they last is a different question. But absolutely try it if you can, if the cornea is clear enough. You should absolutely try that before proceeding to surgery. Do you recommend iridozonulohyaloidotomy in a phakic patient, laser? Yes, you can do it through a peripheral iridectomy. So that you can, yes, I would still try it. It's hard, you don't always know how deep you got, but you try to make a big iridotomy, and then go through that. What about pars plana vitrectomy in malignant glaucoma? So yes, you can go in through the pars plana and have your retina doctors do a vitrectomy, or if you do vitrectomies through the pars plana, you absolutely can do that. But by itself, a pars plana vitrectomy is not the treatment for malignant glaucoma. You have to, after the vitrectomy, establish a pathway up from your vitreous, through the zonules, through the iris, into the anterior chamber, and big enough that it stays open. Yeah, so this is an interesting question. Regarding intraoperative fluid misdirection, how do you differentiate it with suprachoroidal hemorrhage when the lens is already obscuring the posterior view, because aspirating the vitreous will precipitate a suprachoroidal hemorrhage? So you certainly don't want to stick a needle in the back of the eye without knowing what's going on back there. It's always good to have a way of looking in the back of the eye in the operating room. If you have a lens that you can use to look in the back. If not, you can look for a red reflex. So if you have a red reflex, have the patient look up, down, right, and left, and you have a good red reflex, it's unlikely that you have a significant suprachoroidal hemorrhage that would be causing the shallowing of the anterior chamber. So with aqueous misdirection, you're going to get this tense front part of the eye, but you're going to have a perfect red reflex. I mean, it's not going to alter the red reflex. So I think that's probably your best bet if you don't have an indirect in the operating room. What is the disadvantage of transscleral diode laser for recalcitrant patient? I guess it's versus lifetime atropine. I think it's something that really needs to be studied. I mean, I think it's an intriguing issue. You don't want to do enough diode laser that you have that popping. You want to contract the ciliary processes. And perhaps there's even a role for endo photocoagulation, where you go with the endo probe to actually laser the ciliary processes. That's used for angle closure at times also. So I imagine just changing the ciliary process interface, and you can shrink down those ciliary processes by whatever means. But you have to be careful with this transscleral, because you don't want to just burst them. So you want to do like a low, slow contraction burn. But I think this is an area that really needs to be studied more. When you do, there's a question, TREB and phakic eye having angle closure glaucoma risk factors. So atropine. So when you're doing a TREB in those people, you really need to keep them cyclopleged. There are some people, if the patient has had a full-blown malignant glaucoma attack in the other eye, then you may want to do a vitrectomy, iridozonulohyaloidectomy before the surgery. But certainly, if you do that TRAB, keep them seriously cyclopleged and watch them very closely. And the first sign of any problem, you would definitely want at least to do the laser. So the question is the management protocol the same for intraoperative malignant glaucoma in pediatric congenital cataract extraction? So I am trying to, I am not speaking from experience, but certainly atropinizing is important still. And I would be a little afraid to do your posterior capsulotomy when they're in this, when they're right in this aqueous misdirection. But if you do and go right in with the vitrector, I'm going to defer that, and if I can always, if you send a message through CyberSite, I can really get better information on that. When would be the best time to approach that? Can you consider malignant glaucoma in acute angle closure attack, especially in younger individuals with no significant cataracts? So anytime you have high pressure and angle closure, you have to go through the entire differential. So not everyone is primary angle closure. So anytime you have an angle closure, you have to go through the whole differential. So you should absolutely consider malignant glaucoma in people of any age. So certainly it gets more common as we get older and our chambers get shallower. But it can happen at any age, especially in nanophthalmic eyes and in any small eye with shallow anterior segment. So what are the settings for vitrectomy with hyaloidozonulectomy? High or low aspiration, high or low cut rate? So I usually use a high cut rate and low aspiration. I just don't like to pull on the vitreous, but we want to make a nice hole. So it's usually more of a high cut rate and a low aspiration. Why can you stop atropine on why can't you stop atropine on long-standing cycloplegia patients? So you just have, the reason I said to be cautious, I'm not saying you can't stop it. I said just to be cautious is that some people may be on that long-standing atropine because they have a propensity to go back into malignant glaucoma. So sometimes malignant glaucoma is not an acute event. It's kind of a lifestyle. This person is always going to have a tendency to malignant glaucoma and may always need a little bit of cycloplegia to keep them out of trouble. That's not the case for everyone. Most of those cataract patients that get a little bit during the early post-op period, you can taper them off pretty quickly. But occasionally you'll have a person that has severe malignant glaucoma that's can be fairly intractable, and that person you may need to keep on atropine long term. Do you recommend prophylactic surgical IZHV in nanophthalmic eyes during cataract surgery? No. Some do. Some people do. Certainly if you run into trouble in the first eye, I would consider it in the second eye, but most of the time you don't get malignant glaucoma. I mean, you can get effusions. Choroidal effusions are really common. Is much more common just diffuse choroidal effusions, but not necessarily full-blown malignant glaucoma is more common in nanophthalmus. So I do not do IZHV in nanophthalmic eyes during cataract surgery routinely. If the patient had a problem in the first eye, I would definitely go in the second eye. Let's see, I'm just going to read this one out loud and we can work on it together. I've experienced what seems like a mild form of malignant glaucoma postoperatively in a myopic patient. IOL was 16.5 diopters. Postoperatively 5 days, presented with shallow anterior chamber and corneal edema, pressure of 49, resolved on atropine and acetazolamide. IOP normal now, but have not stopped the atropine drops. You can have malignant glaucoma with any refractive error because it's more common in small eyes, and it's more common, with people with high hyperopia. But it has to do with however the relationship with those ciliary processes and the hyaloid zonular interface is. So it sounds likely, if there was nothing on posterior segment exam, what you're describing, aside from the myopia, sounds very classic for malignant glaucoma. In this person, you could probably, since it was acute, it was in a single episode, over time, you may be able to taper off the atropine. This may not be one of those people that needs to be on it for life, but it may have been this inciting event of cataract surgery. It is unusual in a myopic patient, but it's not unheard of. I'm trying to think if there's anything else that would have set this off, but if they had a shallow and central shallowing and a normal posterior segment, there's not much else. So I think this sounds like malignant glaucoma, and certainly it responded to the treatment, which was so beautifully appropriate, atropine and acetazolamide. And I think you should feel safe to very slowly taper off the atropine, but watch them. And if they start shifting more myopic, get them back on the atropine. Is it still safe to use pilocarpine before surgical PI when I'm done during a trab? So yeah, I'm not saying you could never use pilocarpine. I'm just saying if you use it routinely on every post-op cataract, you're going to wind up putting it into some hyperopic eyes. Unbeknownst to you, maybe the post-op staff, the circulating staff will just plunk it in everyone's eyes, and then you're going to put it in some high-risk eyes. So I'm not saying that you can't use it, but just be careful when you do. I know that you're doing it. So yeah, if you want to use pilocarpine before iridectomy, absolutely. We still use pilocarpine often before a lot of PIs in the office. So yeah, just be conscious that it's happening. So I was talking more about beware of, unbeknownst to you, and your surgical staff has a routine of putting pilo in everybody. Know when you're using it is all I'm saying. So is high pressure in one eye with malignant secondary glaucoma risk factors for the contralateral eye? So if you get malignant glaucoma in one eye, you want to really, that's risks for the other eye. So you want to be aware, take necessary precautions. If you're just if you had mild, like with a cataract surgery, you just want to be sure to atropinize. If you had something more severe, you just really want to be aware and take care before. Is vitreous length on biometry useful for diagnosis and follow-up? So we generally use axial length and anterior chamber depth. So I guess you can sort of compute the vitreous length, but usually if you have a shallow anterior chamber, a shallow anterior segment, if you have large lens thickness, high lens thickness, and a short eye, those are definitely going to be risk factors. If vitrectomy is not definitive cure of malignant glaucoma, would you consider cataract surgery definitive treatment? I want to really stress the answer is no. So cataract surgery is not definitive. In fact, cataract surgery can incite malignant glaucoma. So the only definitive is, nothing is ever definitive in eyes, right? The only recommended treatment that has the best results is creating a pathway from the anterior segment to a vitreous cavity and having a fairly nice core vitrectomy. So, so vitrectomy by itself is not going to do the trick because fluid can still go behind that hyaloid. And once it goes behind that hyaloid becomes less permeable and the fluid can't get back forward. And the vitreous cavity, even in a vitrectomized eye, can expand. So you need to have a pathway, a conduit from the vitreous cavity to the front of the eye. So cataract surgery is not going to be the answer. Vitrectomy, if you're going in there to do a surgery for treatment of malignant glaucoma, do not just do a vitrectomy. You're in there already. Do a vitreoiridozonulohyaloidectomy. So someone asked me about an artisan, and I just really don't know what that lens is. Is that if you want to put in another text, is that an iris lens? Is that an iris fixated lens? Those kind that are in the pupil? So if you want to just put another chat in. So I just don't have experience with that lens. So just let me know what that is. So there was a question about how atropine and other glaucoma drops affect the heart in the long duration. Atropine, you could certainly decrease the systemic absorption of any medication with punctal occlusion. So, pressing right in here to close the puncta. And keeping your eyes closed. So each time a patient blinks, it drives the fluid through the nasolacrimal drainage system into the nose, and from the nose and the pharynx, that's where medications get absorbed systemically. They don't get absorbed systemically so much from the eye. So with any glaucoma medicine, if we can encourage punctal occlusion, pressing here, keeping the eyes closed, I I tell patients, listen to a song on the radio, or it's a really nice time to meditate and really rest. And meditation has been shown to be really helpful for glaucoma. So you can really increase the absorption of the medicine in your eye, decrease the systemic absorption, and help lower your intraocular pressure and improve your total body health by meditating for 3 minutes like this with your eyes closed, or listen to a song on the radio. It's probably, I tell people, it's probably the only relaxing time you're going to have all day. So just enjoy it. But so that can decrease if you have concerns about the glaucoma medications. Atropine, I mean, it can have effects. I mean, I've seen people that take a lot of atropine have trouble with urination. I don't think there's any long-term research that shows it's detrimental to the heart. Certainly our other glaucoma medicines can have systemic side effects. This particularly our beta blockers and our alpha agonists can have effects on cardiac function. I'm not sure they're necessarily long-term detrimental to the heart, but we do like to try to decrease systemic absorption as much as possible and increase ocular absorption with nasolacrimal duct obstruction. Right, so if the Artisan lens is this iris claw lens, I think that that could be a problem in creating a unicameral eye. I don't know how tightly they fit. I have like one patient at this point that has one of these lenses, so I really don't have good experience with it. But if you're trying to establish a unicameral eye through the pupil and that lens blocks, then that could be a problem. I think it's unlikely that they're going to completely occlude the pupil, because then everyone that had an Artisan lens would need an iridotomy, and I'm not sure that everyone had an iridotomy that had an Artisan lens. So I don't have a firm answer on that for you, but most iris claw lenses that I've seen in the past had areas for aqueous to percolate. I don't think it would be ideal, but I don't think it would be an absolute contraindication just because it doesn't completely occlude the pupil, but I don't think it's ideal. If one is at an area where a laser facility isn't available other than atropine and an iridectomy, what can be done? Atropine, aqueous aqueous suppressants. And then if that doesn't break the attack, I mean, you can try, oral or IV Diamox, you can try some mannitol or other hyperosmotic, but if that doesn't break the attack over a few days, you're probably going to need to go in surgically and do a vitrectomy with iridozonulohyalidectomy. Can you use tropicamide instead of atropine? It's just not going to give you enough cycloplegia. So tropicamide is a much better mydriatic than cycloplegic. So the strongest cycloplegic is atropine, next strong is homatropine, then, which I guess is scopolamine, then cyclogel, and then tropicamide. Tropicamide has much more dilating properties and much less cycloplegia, so it usually is not enough. And in fact, one of my cataract patients that I treated in one eye with atropine, the other eye I didn't have atropine, I used cyclogel, and that was not adequate. They went into relative aqueous misdirection with the cyclogel. I mean, there's a general glaucoma patient. What do you recommend for a pediatric patient with 2 glaucoma drainage implants with 2 lowering IOP drugs? And the IOP is still 25 to 30. I'm assuming this patient had angle surgery already. Certainly, if this patient did not have angle surgery and it's a pediatric glaucoma patient, I would do GAT procedure. I would go in, or any kind of goniotomy procedure. So I'm assuming that if this patient has 2 tubes, they already had goniotomy, but if not, I would do that. Other than that, you probably want to do a little bit of diode laser cyclophotocoagulation. This has nothing to do with malignant glaucoma, but this was a question that was up. What do you recommend for pediatric patient with 2 glaucoma drainage implants and 2 IOP lowering drugs? So GAT, if they haven't already had a goniotomy procedure or any other trabeculotomy, angle procedure. And if not, probably at this point, a little bit of just a very gentle diode treatment. Is atropine a routine post-op drop for all your post-cataract hyperopic patients? If so, how long and at what frequency? And do you routinely not use Myocol in these patients as well? Absolutely no Myocol on post-op cataracts that are hyperopic. So that's where, when I was mentioning, you don't want to have your OR have a routine where they're dropping pilocarpine in everyone, because if you drop it in your hyperopic patients, you may put them over the edge and send them into malignant glaucoma. I don't use atropine on every hyperopic patient, but any hyperopic patient that has a particularly small eye, anyone that needs over 30 diopter lens, I will use atropine, and even like 28s and up. But if they have angle compromise, so this is assuming that you have gonioscoped every one of these patients, which you should be doing because every patient deserves gonioscopy. And especially if you have hyperopic patients, they all deserve gonioscopy. So know what you're dealing with, know what your angle looks like. If you have a compromised angle going into cataract surgery, they have some PAS, borderline, maybe they have an iridotomy, maybe they don't. You're going to treat it with, you treat their narrow angle with cataract surgery. You want those patients that are at higher risk, you want to treat those with atropine. Sometimes you can just give them a drop in surgery at, beginning of case, end of the case, or at least at the end of the case. Sometimes when I see them the first post-op day, I'll just put one drop in, and that may be enough. If they've had malignant glaucoma or relative aqueous misdirection in the other eye, I will keep them on it for a little bit longer, maybe a week or more. I'm not sure what the question is, but it's about someone that has a normal disc, but a superior visual field defect. So, so discs, this is just has nothing to do with malignant glaucoma, but if discs can sometimes fool you. So you always want to make sure you know about what disc you're looking at. And if you have a disc that's small, so you always want to know the size of your disc. If you have a disc that's small, you may miss the fact that there's glaucoma in there, because you can have a 0.2 cup and have glaucoma, because a small disc should have small to almost no cup. But that's a whole nother lecture. And actually, if you look at there should be posted an optic nerve lecture that I did. That should be posted on CyberSite. That will have a lot of answers to those questions. Have you tried doing a vitreous tap in these cases? Yes. So if you have intraoperative aqueous misdirection, you're operating, everything's going great, and all of a sudden, like, you take your probe out and the iris comes out with you, you try to put some viscoelastic in and the eye gets firm right away, but the chamber's still shallow, and you have a good red reflex everywhere, you looked in the back and everything's fine. That's when you start to plunk atropine on the eye, start to put some mydriatics as well, but definitely atropine, maybe some epi or neo. Try to wait a little bit, maybe give a little mannitol, but if not, ideally you put in a 25 gauge trocar and do a little vitrectomy. If you don't have access to that, a 25 gauge short needle through the pars plana will usually do the trick. Your retina doctors will not necessarily be happy that you did that, but it is rare to have a problem from that. You don't want to pull back hard on the plunger of your syringe. You just want to release a teeny bit of aqueous and a teeny bit of aqueous pockets from the vitreous cavity, and a teeny bit that eye will deepen and soften to be able to finish the case. And then you want to finish your case and you want to keep that patient on atropine. So atropine, wish I had stock in atropine. So yeah, atropine for the treatment of malignant glaucoma and aqueous suppressants. Well, I think we might have come to the end of the talk. It has been such a pleasure to interact with all of you. And I can always be reached through CyberSite if anyone needs anything. And I wish everybody a very good day.